So 31-year-old patient. Patient presented with pain abdominal.
Classical abdominal features.
Abdominal distension, and patient was has a tachycardia of 107 and BP was 115 by 76. On per abdominal examination, patient had an diffuse abdominal tenderness with a lump fell at the epigastrium of around 10 into 10 centimeter, and patient had other than that patient there is no guardian or rigidity, and bowel sounds are present. And ultrasound findings, it showed 600 cc of collection.
What did you find in the abdomen, sir?
So in the abdomen, I could find a lump in the epigastric region of.
This is the lump.
Hepatomegaly is there.
There is massive
Massive.
hepatomegaly. Where is the marker? We used to have it with us.
It is, yes, sir.
Liver is palpable. We've already done the palpation. That's the bulge which you are referring to. And is there any free fluid?
Yes. So they have not mentioned about the free fluid.
So the ultrasound shows a 600 cc in segment 7 and
200
200
cc
cc in the left lobe and in 4A 4B and a rent of 2.5 centimeter.
For liver abscess, earlier they would do the jarring test. Now we just percut and there is tenderness, which is a feature of liver abscess. Even if it is ruptured, it is loculated because it is confined.
Yes.
Because the rest of the abdomen is soft.
Yes, sir.
Yes, sir.
And where all it can rupture?
So it can rupture into the pericardial cavity. It can rupture into the pleural cavity as well.
Pleural, pericardial and peritoneal
Peritoneal.
cavity.
Yes, sir.
So where is this ruptured?
It is ruptured into the peritoneum.
Is the pleura absolutely fine? Can I see the X-ray? Almost invariably you'll find some effusion.
Yes, sir.
It is reactionary, but here you don't see much of it. But you can see there is a tenting of the diaphragm being pushed up. And the patient is not looking otherwise also very healthy. Is he a known alcoholic?
Chronic alcoholic, sir.
sir.
So you should have told me the whole story. What is the significance of knowing alcoholic or not? Alcoholics tend to get more of pyogenic abscess and they tend to have a worse outcome. They often present with jaundice. Which one is this? Pyogenic or amoebic?
Pyogenic, sir, most likely.
Multiple, likely to be pyogenic. And why does that produce more of these features? Because of ascending cholangitis and associated septicemia that may happen. Ascending cholangitis leading to multiple abscesses is the way it happens mostly. Amoebic liver abscess mostly solitary, confined to the posterior superior right side of the lobe. What are we doing now?
So we are planning for interventional radiology for pigtail insertion but the patient's blood parameters are completely deranged. His bilirubin is raised 3.1 and
When will you decide to operate?
so if the patient, first I'll assess the general condition of the patient. If there is hypotension and tachycardia and along with that per abdomen if the patient develops features of peritonism, then I would like to go for exploratory laparotomy.
Anything more?
So same Apache, as per the Apache score, sir.
That's right, score, but actually when the patient has features of peritonitis, you should operate. And you can always do a closed drainage in most cases. But then if it is ruptured or there is an impending rupture, some people believe that you should go in faster. But you can use interventional radiology for this purpose. What is deranged when you
So
say?
his KFT is also deranged and LFT. Urea is 100 and...
Why is KFT deranged, Ayush? Why should KFT get deranged, Aman?
Because of hepatorenal syndrome that might be.
One is hepatorenal syndrome, very good. What else? Don't worry about it. You can answer when they don't know, you should know. Maybe you have an answer, they don't have it. So, hepatorenal shutdown. And septicemia. Septicemia can also produce features of
Yes, sir.
renal derangement.
Acute kidney disease.
So that can also be a factor. What else?
Pre-renal, sir, because of dehydration.
Pre-renal can also happen. Pre-renal and
septicemia, prerenal, hepatorenal.
So you can have all three types, right? So you need to take care of that. How much is the urine output now?
Urine output is around 600
600 ml. But urea is 149, sir, and creatinine is 4. And bilirubin is also raised 3.1 with deranged enzymes, elevated enzymes, and ALP is 1131.
What antibiotic you putting on, Ayush?
Sir, double dose metronidazole also. We have liver abscess and sir, monosep for
Monosep for what?
Sir, E. coli coverage, sir.
Yeah. What are you saying in between? E. coli and what else?
Sir, E. coli coverage.
Because you suspect it to be ascending cholangitis also, no? So you would like to have that.
30 years old female. Patient operated for emergency open appendectomy on 15th of this month, and patient was discharged the next day. Now patient presents emergency with shortness of breath and tachycardia. Patient has been admitted from outside for the same, sir. Right side chest. Right side chest pleural effusion is there on.
So X-ray also shows right side pleural effusion. We had sent a medicine call also for that, but they have only sent back the patient to manage the post-op surgical complications.
So why do you think it has happened? I'm going to close that door. Sister, close that door, please. Don't keep it open.
So in the post-operative period, we suspect atelectasis to be one of the complications.
Okay, one.
Sir, in the setting of acute appendicitis, perhaps because the history was they had done open appendectomy with drain insertion. Perhaps it was perforated and the collection had swept and collected into the subdiaphragmatic space. That might lead to shoulder pain and.
No, that she's saying. I thought you were saying something else. There is a subdiaphragmatic collection with a basal atelectasis. That's one possibility.
Yes, sir.
What else? Therefore, it's very important to make sure that it was not a negative appendicectomy. You should be very clear that it was actually appendicitis and not some other pathology like tuberculosis or something else, where this could be coexisting. That's number two. Number three, you should also make sure that, during surgery or following that, there was no element of portal pyemia or something. Portal pyemia is also a possibility following appendicitis. So we need to be careful about it. Portal pyemia is an ascending infection occurs along the portal vein. And it can produce multiple liver abscesses, right? So that also is a factor. So you got an ultrasound done?
We got an ultrasound done for this patient, and ultrasound revealed that there is no dilated bowel loops, and also
Abdomen is okay. Anything else you found? Anything
other than
significant?
there is
Sir,
collection
X-ray
of
shows right side pleural effusion.
collection in the right
That is-
Now, how can you proceed from there, Raman? If the X-ray is showing pleural effusion.
So we can proceed with the ultrasound guided to right.
No, you got a pleural effusion, all right. Ultrasound is suggestive. What is diagnostic for pleural effusion? This you taught in your MBBS time, no?
Sir, diagnostic is a TAP, sir.
Tap, very good. So once you tap it, can you make a diagnosis based on that?
Yes, sir, we can send for.
No, you don't have to send. You look at it, what do you find? If it is a reactionary one which you were talking, it will be transited. If it is a pyogenic one and it's purulent, then it will be extra. Yeah. So that's what you got to look for. Understood that case? Even if you are referring it to S4, you should at least make a diagnosis, okay? So if you have effusion on the right side, if you have post-appendicectomy patient, the scenario is clear. So what all comes to your mind? 1, 2, 3, 4, 5. For MRCS they ask you. Classical scenario, this is asked.
So we must rule out possibility of tuberculosis. It would be.
1, 2.
And sir.
So first find out whether appendicectomy was correctly done.
Yes.
And for what was it done, right? Second, what next do you do? You try to
Sir,
look for.
sir, as the ultrasound showed, the liver is fine, sir, and there is.
No. What? I'm
Possibility.
revisiting the scenario. You're answering the same monotonous way. What's the point?
So pleural effusion, we would like to do a diagnostic tap.
No, that's one. Effusion, you're thinking it could be
Reactionary, or it could be tubercular.
tubercular. No, not tubercular. It could be itself the cause. We don't know whether it's tubercular or not. Right? So reactionary or exudate.
Yes, sir.
Two, you are not getting the scenario. Appendicectomy done 1 week ago, Patient has come with right-sided shoulder pain, effusion,
Diaphragmatic collection.
so subdiaphragmatic collection, subphrenic abscess as they call it. Pus somewhere, pus nowhere, pus under the diaphragm. Patient has features of swinging temperature and all those features are there. So that comes to your mind next. Third, there could be a separate pathology in the pleura, which is what you are talking about. Maybe that time patient had the issue. What are the types of effusion if you get? Sympneumonic, post-pneumonic, and pneumonitis also. No? They occur along with pneumonitis, which can happen with basal pneumonitis in patients with limited diaphragm movement. Right crus is not moving adequately, there will be collection. That gets infected and patient has pneumonitis. So these things need to be excluded. What did you find on ultrasound?
So there was a collection of around 7 into 7 centimeters in the right leg fossa,
That is one. And
Right side.
and then right sided pleural
Right, that's
effusion.
one.
So actually, when she presented to ER, she was just complaining of pain while inspiration. So it was kind of pleuritic chest pain, sir. So one medicine opinion was taken, sir. They have done the examination, but they referred because they were suspecting it is post-op complication only. So patient need to be managed on the surgical side. But to me, sir, it looked like some different pathology in the pleura itself because the typical history which she is giving, pain only while inspiration, and pain is getting referred to the shoulder. I was at that time I was also suspecting subphrenic abscess also, but the ultrasound scan it did not show any collection, and only effusion is there, sir. So the pleurisy, so it is a pathology.
that's the same thing you're saying. So basically, it's either a pathology in the abdomen or in the pleura,
Yes, sir.
both causing each other. Yes.
Yes, sir. So, 71-year-old female patient presented to the emergency with non-passage of flatus and stool for the past 4 days, and also pain abdomen. Patient at presentation, his vitals were 85 beats per minute with pulse rate, with BP of 140 by 86, and on per abdomen examination, abdomen was distended with soft, and there was mild tenderness, and then there was no guardian or rigidity. Bowel sounds are present at present.
So what does she have?
Chronic
It's a
constipation.
soft, non-tender
Yes,
abdomen in an elderly lady. She's getting blood transfusion.
Yes, sir.
For
So,
what?
Hemoglobin was 4.3.
So that is this
Patient-
related?
No, sir. Patient had a history of hemorrhoids past
2 years back.
2 years back.
So did you establish it?
So right now when we did the DRE, there was rectum was collapsed. Only fecal staining was there, but there was no blood on the finger stalk, and there was no hemorrhoids are seen, and patients are
See, in an elderly patient presenting with severe anemia for a non-specific cause, what all comes to your mind? What's your name?
Sir, Akshay Chawla.
Akshat, yeah. Now, if you don't know, say you don't know. So
I don't
you can
know.
say one time.
So in an elderly patient with severe anemia, we can suspect malignancy to be the cause of it.
Which
Patient has
side? Right sided malignancy.
yes.
No bleeding on the left side, that's all. 2, Junaid?
The carcinoma stomach, sir. She is giving any history of any dyspepsia, recent onset dyspepsia.
One is stomach, the other is cecum. Third, any non-specific site. Does she have any bowel complaint?
She presented with constipation, chronic
The
constipation.
moment I say elderly, think of malignancy as a hint. Sometimes the only presentation of carcinoma of cecum is anemia, asthenia, anorexia, which is non-specific. But exclude a hemorrhoid if the patient is giving you a history. Now, DRE does not exclude hemorrhoid, you need a proctoscopy. And you should do a proctoscopy for that purpose. She is not in obstruction, and there is nothing surgical that needs to be taken care of just now. But since the patient is here, you might as well manage her for this. She is chronically ill. If she has got anemia, is blood transfusion the answer? What are the risks of transfusing blood in patients that are severely anemic?
so
Volume overload
volume overload.
and cardiac failure. So what is it that you should do? This is a chronic anemia. It is not managed by transfusions. Remember that.
So we need to do studies to rule out the type of anemia first.
What's the type of anemia? Good.
Serum iron studies and B12 studies. Because if it is the iron deficiency anemia, blood transfusion won't help. It will keep on happening. We need to rectify the cause and treat it, sir.
1, 2. If you want to transfuse just to save time and go for something definitive, reduce the volume. So how do you make it possible that the volume goes and patient still gets hemoglobin? So you give packed cells. In
Yes,
that
sir.
case. So transfusion should not be given beyond a point. Elderly lady with such a severe anemia, blood transfusion and overload can cause
Cardiac.
cardiac arrest. Very careful about that. That's what you need to know. He has nothing in the abdomen.
Yes,
This
sir.
is not a problem of obstruction. But the patient could have a malignancy which we can't make out based on clinical examination all the time.
Yes, sir.
Because the cecal malignancy takes a long time to manifest as a lump. The other possibilities are the more than diverticulum. What else, Rishi? There's something that is common on the right side of the colon, not on the left side. Angiodysplasia.
Angiodysplasia.
So we need to exclude it by doing colonoscopy, upper GI endoscopy, and capsule endoscopy, which is what you do in these patients. But patient has first established a type of anemia. If she's got a deficiency anemia, you are unnecessarily wasting time. So we need a good peripheral blood smear, thin and thick. We need the blood picture completely. And based on that, we take a decision on how to transfuse. So don't transfuse blood. This is not something which is a good idea in a patient with severe anemia, especially elderly, because their cardiac efforts are already compensated. Anything else to be done? Nothing else to be done? Then what, do you discharge?
So we'll do the
workup, sir.
pro-
Workup, sir. We must.
So what will you do? I've told a few.
So starting with
the GI,
proctoscopy.
So rule out upper GI, lower GI bleeding, and then the obscure GI. What is obscure GI bleeding?
When, sir,
Rishikesh.
yes, sir.
Okay.
So when we could not establish the cause, when there is no upper GI bleed after the upper GI endoscopy and even after the colonoscopy, we could not find any lesion. Patient is still losing blood in the stools.
So
It is obscure.
blood somewhere, blood nowhere.
Small intestine.
It is in the small bowel. So we like to do a
Capsule endoscopy and push enteroscopy.
push endoscopy, capsule endoscopy,
A virtual.
or you can do virtual colonoscopy. What is that?
So it's a three-dimensional which we
Non-invasive. Method of assessing the gut. Read about that. Or this patient, first of all, established a type of anemia. It's very important. Sometimes we are dealing with a different kind of anemia and you are trying to find a cause somewhere.
If it come out in the paper, if it's come out to be anemia of chronic
It's a
disease,
deficiency
then
anemia, then you are wasting time.
Yes, sir.
How did this patient land up in surgery?
So she presented with the non-passage of stool and flatus and
See, the
was-
problem with non-passage of stool and this thing is, almost everybody who has not eaten for 2-3 days will have it.
Yes, sir.
So our triaging system needs improvement in that way. You get the third patient. Any patient with chronic liver disease will have ileus. Ascites leads to ileus. It's a known feature. And ileus is not just an obstruction.
yes.
So the trouble is, if you are an illiterate in the clinical field, you'll keep referring patient here and there. That's what is happening. That patient has no business to be in surgery. Yes, Vikram, you're doing fine, right? So don't worry.
So 17-year-old female patient presented to the South-African emergency with pain in the right iliac fossa for the past 2 days. The patient had tachycardia of 180 and BP of 120 by 68. On per abdomen examination, there was tenderness, localized tenderness present in the right iliac fossa with while the rest of the abdomen was soft, non-tender, there was no guardian or rigidity. Bowel sounds were present. On ultrasound findings, it showed acute appendicitis. And
You need ultrasound for this? You don't. Appendicitis is a clinical diagnosis. But since you mentioned ultrasound, so Aman, what are the features on ultrasound that make a diagnosis of appendicitis? I want to remove from your head this first year PG syndrome. That you won't answer because you're a first year PG. No, you must answer even if your final year doesn't know. SR also doesn't know, doesn't matter. You answer. If you don't know, say you don't know. Don't waste time.
Sir, non-compressible tubular blind ending structure of more than 6 mm is diagnostic with peri-inflammatory feature.
One.
Edematous wall. Say edematous wall.
One second.
Edematous wall, sir.
Okay.
So blind ending non-compressible aperistaltic structure of more than 6 mm in wall-to-wall diameter with the surrounding ecogenic.
क्या आगे बोलो? What he has spoken, if you are repeating, what's the point? Yes?
So surrounding collection in the right iliac fossa.
That they have mentioned, beyond that. Aperistaltic means what? What is aperistaltic, sir?
It's not moving, so it's not.
Why should it move? What is the basis of this sign?
It's inflamed adhesion.
Everything is related to obstruction at the base. And basically there is a double circle sign. A larger circle is for the cecum, smaller is for the appendix. And ultrasound. If you press on the larger one, the smaller one should distend. If there is an obstruction, if there is obstruction, this is suspicious of appendicitis. All appendicitis is obstructive mostly. Catarrhal is very rare. That is why appendicitis is not common in very small children, because their base is wide. Is that clear? So, and what are those two constant symptoms and two constant signs that you must get?
Symptoms are signs are tachycardia and tenderness.
Tachycardia is a sign. No?
Tachycardia and tenderness.
Symptoms.
Symptoms are
Sir,
Pain.
anorexia and sir,
Anorexia and
migratory pain, sir,
shifting.
shifting pain.
Signs, tachycardia and
tenderness.
so there is no appendicitis patient who has good appetite, and there is no appendicitis patient who has bradycardia. So these are two constant features. Did you find anything on abdominal examination? कैसे हो अभी पहले से आराम है बेटा?
हाँ.
हाँ? मुंह उधर ही रखो, तुम तो सो के उठे हो, तो इसका मतलब आराम से सोए हो?
Throughout night, sir, she was not complaining of any pain, and there was no tenderness also.
घर
with
का है
the
तुम्हारा?
iliac fossa.
It's okay.
गोविंदपुरी में.
हैं?
गोविंदपुरी.
गोविंदपुरी. Okay.
So,
करवट ले लीजिए.
depreciative base lump.
I think there is nothing.
Yes, sir.
We do this shift test because everything else falls apart. And what is the shift test that we do, Junaid?
Sir, we need to rule out ureteric colic versus the
No,
appendicitis.
that's not shift test. You disappointed me.
So it was done in pregnancy. So it was done in
It's
pregnancy.
done for pregnancy cause induced pain in the right iliac fossa. Pregnancy, you can have uterine pathology or a tube pathology. So this was confused with appendicitis. Appendicitis diagnosis is difficult in pregnancy because there is distended uterus. So if you do, you palpate for tenderness like I did just now. So this is a tender point. This is it. Then I ask her to tilt. Forward Lily. And look for tenderness again. If it is shifted, that would be uterine. If it is not shifted, it will be.
Appendicular.
That is a shift test. Don't mix it up. How will you differentiate between the ureteric calculus?
Sir, if it other patient is shift, sir, the tenderness, if tenderness stays there, sir, it is the uterine or ureteric.
Disappointing.
So it might be associated with burning maturation,
So
urinary
first points in
complaints.
history. Burning maturation can happen with appendicitis also. In pelvic appendicitis, which is irritating the ureter, you can have hematuria and burning.
Classical loin to groin pains.
Huh?
Loin to groin pains are the
Loin to groin pain to bradycardia, which is colicky. And appendicitis will produce tachycardia. Secondly, tenderness is absent in ureteric colic. Appendicitis is tender, but ureteric colic can simulate it. There is a cuff test that they do, which you read in your books. On cuffing, if the pain gets worse, is appendicitis, because muscles are used. And ureteric, don't matter. So what is it now? Settling appendicitis, but you got an ultrasound done, now you got a diagnosis of appendicitis. If you were practicing, you would say, just take the appendix out. This is not what you should do. What is the differential diagnosis of appendicitis in this age group? Specific question.
lymphadenitis, sir. Mesenteric
Keep
lymphadenitis.
finishing, I didn't stop you. One lymphadenitis.
Arsina enterocolitica. I'm being
These two.
So ileocecal tuberculosis, mucosal
I
and
said this age group, I have specific.
Ruptured ectopic.
Ruptured ectopic, okay. What is
Mitchell
metal
merge.
merge?
Sir, with the rupture of the ovarian follicles also during the cycle.
It's a
she can
mid-cycle
have-
pain.
Mid-cycle.
Which can actually simulate, which absolutely looks like appendicitis. There will be pain which is referred to umbilicus. Why is the ovarian pain referred to umbilicus? Same dermatome, T10.
T10.
So both for appendix, for testis, for ovary, it's T10. So that Mitchell merge also will produce rupture, blood will irritate the peritoneum, and you'll have guarding, rigidity, and all those features would also appear. Important to understand. Exclude that. Take therefore a good menstrual history, which you should have told me. The other thing you should have told me were those basic important features which differentiate appendicitis from all the other features. To be observed, don't operate.
So 32-year-old male patient presented to subdural emergency with pain abdomen and abdominal distension with non-passage of letters and stool for the past 4 days. At presentation, patient had a tachycardia of 130 with BP of 110 by 78, and on per abdominal examination, patient had abdomen was distended, and on palpation there was
What do you see here?
so the umbilicus is
Transversely stressed,
transversely split.
which means flanks have fluid.
Yes, sir.
This is fluid, should be. Okay.
Yes, sir.
So what else did you find?
Upper abdominal examination, there was diffuse abdominal tenderness with guarding present, and bowel sounds were absent. His chest X-ray erect showed gas under diaphragm.
You can see it also.
Yes, sir.
This is resonant, no? Liver dullness is masked. So,
Absence of liver.
so clinical, not absent, masking
Masking.
of liver dullness. And this is a surgical abdomen, clasp. So what's your clinical impression, Rikhot sir?
So most likely this patient is a case of perforation peritonitis,
Perforation of liver?
bowel.
Can it be stomach also? So don't use that term. Perforation of hollow viscous.
Hollow viscous.
So the correct term is, okay?
Yes, sir.
Perforation of hollow viscous. In view of the features of peritonism, masking of liver dullness, and the history you have given, which type of perforation it is? Is he a known alcoholic?
So he gave history of alcoholic intake.
So he's a chronic smoker.
So what is it that you have not told me which you have, which would have an impact on the management?
Patient history of TB as well, and
Bowel perforation being managed in our unit.
upper chest.
We need the Apache 2 scoring. How much is it?
So we do not have the blood investigations. He came in the morning only, so we could not calculate.
How would
But-
that matter, Rikhot sir?
So with the aperture scoring, we can for OT management either we can do an allotransverse anastomosis, or we can
We can decide whether to urgently have some intervention in the patient, place an abdominal drain, sir, or sir, if there is a perforation, we can decide about repair of perforation, sir, or sir, making an ileostomy, sir.
So the Apache score can be divided into 3 ranges: less than 10, 10 to 20, and more than 20. When the score is less than 10, then the patient is vitally relatively stable, so we can go for resection anastomosis.
We can go for closure, primary closure, and we can go for anastomosis. We don't have to exteriorize. Between 11 and 20 we will
Exterior.
More than 20.
preferably
Optimum.
exteriorize, and more than 20 you won't take up for surgery. You'll resuscitate like we're doing for that case. We'll put in drains in the flanks, do some lavage, and when the score improves to group 2, we manage it as group 2. What antibiotics you have put him on? Brother, what is he getting?